My name is Shriyans, and my topic that I'm speaking about today is physician-assisted suicide. So the agenda that we're talking about, I'm first going to talk about what is PAS, then the moral issues to PAS, then my thoughts about PAS, a discussion more about PAS, and then a response to potential arguments about PAS. So starting off, what is PAS? PAS is physician-assisted suicide, and physician-assisted suicide is a medical practice where doctors give terminally ill but competent patients a prescription of medicine at a lethal dose. The request for medication has to come from the patient in a voluntary and informed state. The key aspect of PAS is that the patient has to perform the final act of administering the lethal dose of medication. A common misconception is that euthanasia and PAS are the same. However, the key difference is that the physician administers the lethal dose of medication in euthanasia. In PAS, the distinction lies where the patient has the final action, while in euthanasia, the doctor can take the final action. A little bit more about the moral issues that come with it. So the debate over PAS hinges on the conflict between the value of patient autonomy and non-maleficence. On one hand, patient autonomy says that people have the ultimate right to decide what happens over their life. This means that terminally ill patients facing a future of pain and suffering should have the ultimate authority to end their life. The patient should have the ability to control the timing and the methodology they choose to take their life. The patient, even if terminally ill, should have the dignity to utilize their last option in the face of unbearable suffering that has taken away all their other choices. On the other hand, the principle of non-maleficence is the physician's absolute principle to protect life and fight diseases within patients. From the non-maleficence point of view, a physician's involvement in a patient's death is a violation of their role as a healer for society. This is discussed by Brock when he describes any sort of killing by medical professionals as violating their fundamental way to protect life. In the medical field, when approaching the problem from a non-maleficence lens, killing as a doctor can erode trust within the medical field and collapse the moral code. While this viewpoint is extreme, this can occur if non-maleficence isn't upheld. And this forces us to ask a difficult question. In the context of modern medicine, which can prolong the dying process almost indefinitely, what does it truly mean to do no harm? So more about my thoughts on PAS. In this, I will argue that physician-assisted suicide is a moral and a compassionate option that must be available to people who are mentally competent but have lost the will to live and are dealing with unbearable pain and suffering. I stand on the belief that individual autonomy, which is a fundamental right to determine one's fate and medical outcome, should be the primary factor in the patient's end-of-life situation. This point is supported by Coward when he speaks about his view of patient autonomy. According to Coward, a competent patient should have the complete control over their medical treatment, which is stated in Coward's argument on page 17. Even in situations of very bad accidents, patients should have the right to refuse life-saving treatments. However, the patient must fully be informed about the choices they are making. This is stated on Coward's argument on page 18. If people have the right to refuse life-saving treatment which kills them, why shouldn't they be allowed to use PAS to end their suffering as well? Patients should always be allowed to make their own medical decisions since they understand their own pain, values, and wellness more than any other external source. And since doctors don't live in patients' body and undergo the same exact challenges that patients go through. However, a key part of PS is that people have different tolerance to pain. This could be mitigated, however, by psychiatric evaluations of patients' wills to live. If a person doesn't have the will to live, the medical professionals shouldn't have the power to force them to endure unbearable suffering. Also, if the medical professionals deny a patient's request to physician-assisted suicide, the denial doesn't follow standard medical procedures. The medical system allows patients already to refuse the right to life-saving treatment that eventually leads to patient's death. An example of this is Jehovah's Witnesses, and where they refuse blood transfusions even in life or death situations. If the medical system allows them to die, why isn't there a way for people to access PAS as well? To forbid a patient from receiving lethal doses of medication, however, to allow them to suffer by allowing them to refuse treatment doesn't work. Both are voluntary choices to end suffering. However, physician-assisted suicide is a faster way to the same result that we already allow. And a little bit more about the discussion. Moving forward, I want to present a significant objection on in one of our course texts that we're studying, which is an article by Carr. In our article called "Legalizing Assisted Dying is Dangerous for Disabled People," Carr primarily states that physician-assisted suicide places the disabled community at risk. Carr's first point is that physician-assisted suicide creates a double standard. She said that when healthy people have lost the will to live after endless suffering and they take their life, it is seen as a tragedy and we provide support to this individual. However, when a disabled person loses the will to live after suffering and takes their life, that choice would be seen as rational. Carr calls this wrongful pity since it places value on each individual life depending on that life. Carr also describes this action to be dangerous to the disabled community since it places a notion that disabled lives are worth less than non-disabled life. The last point that she makes that within her article is that disabled people will feel like they have the duty to die if physician-assisted suicide is implemented. With this, the freedom of choice is limited by social factors which don't empower people to make the best situation for themselves. People with disabilities, who sometimes feel as a burden financially or socially to their friends and families, will be pressured to choose death if physician-assisted suicide is implemented. To support her argument, Carr cites data from the state of Oregon that people with disabilities choose PAS from fear of being a social or financial burden to the people around them who are close to them. Carr states that this choice is not truly free since society doesn't offer support, but rather misplaced pity to the disabled community. However, moving on to my response to the potential objections. So Carr has many valid points. However, these points are not a reason to prohibit physician-assisted suicide, but to regulate it to the extreme. In response to the first double standard argument, PAS is not based out of pity, but rather out of autonomy first. The person's is out of autonomy first, regardless of the person's disability status. If there are two patients that are suffering immensely and have lost the will to live, each should have the right to decide their medical future. If the medical staff prohibits the disabled patient from accessing physician-assisted suicide, this creates a slippery slope and sets the precedent that the disabled community cannot make decisions for themselves. The decision to access PAS should solely rely on the patient, regardless of external or internal factors, once the medical staff determines that the patient is competent and has lost the will to live after explaining other solutions to the patient's problems. In response to our strongest point about fear of being a financial or social burden, this is a clear showing of our society's failure to provide adequate care to the most vulnerable people. This means that we as a society should improve our social support. However, this doesn't mean that we should deny the final request to a patient, even with quality healthcare will suffer immensely. The solution to this is to require counseling on all the different options and increase social support so that the final PAS choice doesn't come from a lack of social support, but more from a patient's own perspective and patient autonomy. So this is also my works cited. I used Liz's argument, Cowards, and Brock's.